Good morning. Welcome back to Open Med School. I am Dr. Andrews, Professor of Medicine, Consultant Neurologist. Today I'll be discussing heart failure, pharmacological management. This is internal medicine competency 1.24. Traditionally, heart failure is being treated by additional drugs, but the newer guidelines says that this drug should be started in combination early rather than adding on sequentially. So let us discuss the management. So the foundational therapy for heart failure with reduced ejection fraction consists of 4 classes of drugs that should be initiated early and in combination. So simultaneous use of the disease modifying drugs, not delayed sequential therapy. That is the point to be mentioned. So let us see what are these 4 pillars. When a patient comes with heart failure and there is evidence of fluid retention, of course, diuretics are the first choice. So diuretics when there is a fluid retention, like edema, features of pulmonary edema. And the 4 pillars are the first and foremost is ARNI. That is the angiotensin receptor neprilysin inhibitor or ACE or ARB. ARNI is preferred over the other drugs. Second is evidence-based beta blockers. So remember the term evidence-based beta blockers. Then comes the mineralocorticoid receptor antagonist, and finally the SGLT2 antagonist. And these are the 4 pillars of management of heart failure. So as mentioned, diuretics are only whenever there is a symptom relief, and the digoxin in selected cases. Hope this point is clear to you. So let us start with we'll start with a case. This is a history of a 58-year-old gentleman. He has come with dyspnea on exertion, NYHA class 3. Patient has got pedal edema, basic repetitions. Is a diabetic and hypertensive. His vitals, BP is normal, heart rate is 92 per minute. Echo shows ejection fraction 30%. And the creatinine is normal, 1.1, potassium is 4.4. So what should be the treatment in this patient? Definitely this patient has got features of fluid retention, as evidenced by the basic repetitions, which indicate that there is pulmonary congestion and patient has got pedal edema. So definitely the patient should be started on diuretics. Diuretics are recommended to relieve signs and symptoms of congestion in heart failure. So remember this point, the patient should be started on diuretics. Then comes what diuretic will give. It is a furosemide that is to be given. Furosemide given 20 to 40 milligrams per day orally, and you may titrate it upwards. Start with 20 to 40 milligrams of diuretics. And of course, you know that the mechanism, it decreases the preload, it relieves the symptom and the relief of edema and dyspnea. It decreases sodium and water reabsorption. So pulmonary congestion, peripheral edema. Remember, it has got no mortality benefit. It improves symptoms only. So diuretics are given for symptomatic relief of heart failure. Okay, now we go to the main pillar. The first pillar is the ARNI. ARNI is superior to AC inhibitors in reducing mortality and heart failure hospitalization. So the preferred RAS blocker is ARNI. The mechanism, the sacubitril, which inhibits neprilysin, increases the natriuretic peptides. So natriuretic peptides are destroyed by neprilysin, which is inhibited. Valsartan blocks the RAS. It decreases remodeling, decreases preload, afterload, and increases the survival. So the recommended dose is standard patient 4951 milligram BD can be increased to 97 103. So the preferred RAS blocker is a combination of Neprilyl inhibitor and valsartan. That is the sacubitril valsartan combination. Which are situations where this drug should not be given, should be careful. If the BP is low, should not be given. The elderly patients should be careful. When there is renal dysfunction, the dosage should be reduced to 26 milligram, 24/26 BD as tolerated. So how to initiate the treatment? When patient is not on AC or ARB, you can start directly. No washout is required. Ensure that the BP is more than 100 millimeters of mercury systolic. Start with a low dose and titrate over every 2 to 4 weeks. In elderly, you start with a 24 20/26, and in normal patients, you can start with 49/51 and increase to 97 103 milligrams BD. So patients are sometimes started on AC or ARB. In such patients, how will you start? It's important to remember a minimum washout period of 36 hours. 36 hours is mandatory when switching from AC inhibitor. So if the patient is on an AC inhibitor already, stop the AC inhibitor for 36 hours, wait, then start ARNI in appropriate doses. Monitor the BP, creatinine, and potassium. Suppose the patient is on ARB, no washout is required, you can directly switch over to ARNI. So this is a important point to be remembered. The patient is already on AC inhibitor. You should stop the drug, wait for 36 hours, then start appropriate dose. Hope this point is clear. What are the contraindications? The major contraindications are history of angioedema. Pregnancy should not be given. Serum potassium more than 5.5 and severe hypertension, BP less than 100, usually it is not preferred. So rationale in this case, the case we discussed today, BP more than systolic BP more than 110, ejection fraction 30%. So ARNI is the drug which is preferred. ARNI is preferred over AC inhibitor. Now we go to the second pillar. The second pillar is evidence-based beta blockers. All beta blockers are not equal. You should go for the evidence-based beta blocker. What are the evidence-based beta blocker? One is bisoprolol, metoprolol, and carvedilol. These are the drugs which is given. What is the dosage of bisoprolol? Bisoprolol is given 1.25 milligrams start. 1.25 milligram you can start and increase up to 10 milligrams once a daily dose. And again, remember it's metoprolol succinate. Start with a small dose, 12.5 milligram to 25 milligrams. Gradually step up it to up to 200 milligrams. If it is carvedilol, start with 3.125 milligram up to 25 milligram you can give. So these are the evidence-based beta blockers are, one is the carvedilol, second is the metoprolol succinate, and third is bisoprolol. So again, what is the mechanism? This decreases sympathetic overactivity, decrease heart rate, arrhythmias, and reverse the remodeling. When to start? Patient should be euvolemic and stable. So when the patient is in acute heart failure, coming with pulmonary edema, class 4 symptoms, should not start beta blocker. So acute decompensated heart failure, beta blockers are not given. Suppose patient has severe asthma, should be careful, should not give. Heart rate less than 50 and evidence of AB block should not give beta blockers. So these are the important contraindications already mentioned. Remember these points. Now, the third pillar is the mineralocorticoid receptor antagonist. MRIs reduce mortality and hospitalization in patients with heart failure with reduced ejection fraction. So, what are the drugs which are? So, it has again got a mortality benefit. Spironolactone start with a small dose. The dosage is not that usually routinely we give for cirrhosis. It should be a small dose of spironolactone. Start with a 12.5 milligram. We can increase to 25 milligram. So 12.5 to 25 milligram is okay. Then is the eplerenone 25 to 50 milligram OD. So these are the drugs. Mineralocorticoid receptor antagonists. The indications usually LV ejection fraction less than 35% and consistent symptoms. Persistently, patient has got a class 3, class 4, or class 2, class 4 symptoms, you can start. Contraindication potassium more than 5 because it produces hyperkalemia. More than 5 milligrams should be careful. EGFR less than 30. EGFR less than 30 again should not give. Again, remember, the RAS can produce hyperkalemia, and so you should be careful when the potassium is more than 5. So now comes, we are going to the next pillar, the SGLT2 inhibitors. It is a essential drug in heart failure with reduced ejection fraction. SGLT2 inhibitors reduce cardiovascular death and heart failure hospitalization. It has got a definite mortality benefit, even when the patient is not having diabetes. So the two trials, the Emperor trial and the DAPA-HF, consistently have shown these benefits. So the dosage, DAPA 10 milligram, empagliflozin 10 milligram. So DAPA and EMPA 10 milligram is usual dose. No titration is required. Minimum effect on BP can be started early in heart failure. So the mechanism, the patient can, this will produce osmotic diuresis, reduce myocardial fibrosis, improved myocardial energetics. All heart failure with reduced ejection fraction patients with or without diabetes should be given the benefit of SGLT2. What are the contraindications and cautions for starting SGLT2? EGFR less than 20 to 25 ml. Even then the GFR is less, is not very effective, should not be, or caution should be administered in administering recurrent genital infections. Severe volume depletion, again, should not give. Now we think about the traditional cardiac glycoside. Digoxin reduces hospitalizations but does not improve survival. Dosages can start on a small dose 0.125 to 0.25 milligrams of digoxin daily. What are the indications? Heart failure with reduced ejection fraction with atrial fibrillation. You can start. Persistent symptoms despite optimal therapy. Again, so these are the two definitely you can start to digoxin. So digoxin has got a role in these two situations. What are the contraindications? It is not indicated or it should not be given when there is a risk of ventricular arrhythmias are there, heart block is there, and hypokalemia, because hypokalemia can worsen or it can induce arrhythmias. So now we go into how will you administer a stepwise addition of drugs. So diuretics for relieving the congestion, ARNI for the ARB or ACA, disease modification, beta blockers for mortality benefit, MRA for additional mortality benefit or survival benefit. So these are the definite indications. And SGLT2 inhibitors are given early and it has an independent benefit. Digoxin when there is atrial fibrillation and refractory symptoms. So again, you should remember the drug should be initiated within 4 weeks if possible. So that is a point to be remembered. All these drugs should be given, these 4 pills should be given within 4 weeks. So in the next session, we'll be discussing some MCQs. So, and clinical questions. Why SGLT2 inhibitors can be started early? Why is even if when the patient is not diabetic? It has put rapid benefit, minimal BP effect. Why beta blockers are not started in acute heart failure? It will worsen congestion initially. Why washout before ARNI? To prevent angioedema. So the next session will be coming with some MCQs based on this topic. Hope it was useful to you. Stay tuned. Thank you.